Thank you very much. Thanks for inviting me to the RSM today. It's very helpful to be speaking after Peter, who's really set the scene very well and talked about some of the problems that we face when trying to disentangle the pathophysiology, the biological factors that might be important in this condition. We've already had a description that we don't really know at this stage where the boundary is between chronic fatigue syndrome and the rest of the population with chronic fatigue, which may be extremely disabling but which may not quite meet the criteria. And this boundary is fuzzy, which is difficult when trying to study pathophysiology. We've heard that CFS itself may be made up of a number of different syndromes. And there's also the problem of overlap. When we look at other conditions, we've heard about fibromyalgia, also depression, there's an overlap here. And these conditions have their own biology that we have to try and disentangle when we're trying to understand this. Peter's again touched on this, the other different syndromes. We have chronic fatigue syndrome, but very often patients will have one of these other conditions. And we have to be very careful when we're looking at biology to try and understand that. Now, the sort of model that I think is the best way to try and understand this at the present time is a multifactorial model. Again, this follows on, Peter set the scene nicely, talking about predisposing factors. What is it about some people that leaves them vulnerable to develop chronic fatigue syndrome? Precipitating factors are often present, acting on this vulnerability to lead to an acute or subacute fatigue state. And I think I would argue that the most important things that we've been studying to date are the perpetuating factors, why someone who has an acute or subacute fatigue carries on into a chronic fatigue or chronic fatigue syndrome state for many years. Most, if not all, of the research looking at biological factors is done on patients here in the clinic several years down the line. And we know very little firsthand about these factors from a biological perspective. We know a lot more about these factors. So what are the predisposing factors that we know about? Peter's touched on some of these, but just to summarise the sorts of things we know. There's a female preponderance. If you have a past history of psychological disorder, that increases your risk. There's literature that illness in close family members is a risk factor. This comes from Matthew Hotop's study. And a history of fatigue or other medically unexplained symptoms. But there's also some accumulating evidence that genetic factors are important. The genetic studies, as usual, include the sort of family studies or twin studies, and the genetics, it seems to be clear, some of the genetics relate to the genetics of these factors, and some of the genetics may relate to the actual predisposition to chronic fatigue syndrome itself. And there's an emerging literature that a history of childhood adversity is also a risk factor. One study, this was looking at fibromyalgia, but this also applies to chronic fatigue syndrome. This was comparing with a control group of patients with rheumatoid arthritis. If you look at childhood abuse, much higher rates, and if you look at adult abuse, higher rates of different degrees of abuse. So something about that is important too as a vulnerability factor. What are the sorts of triggers that you can identify? Talked about viral illnesses. I'll say a little bit more about the types of viruses that seem to be important. Stressful life events have been identified as a potential trigger. There's a literature on post-operative stress. There's a literature that patients with depression can suffer from fatigue and develop a chronic fatigue syndrome, certain medications, and there's a literature of post-cancer treatment. This isn't exhaustive. You sometimes can't find a trigger, but any sort of quite severe insults does seem able to trigger a CFS-like condition in vulnerable individuals. This is summarising the sort of literature from the severe viruses, the sorts of viruses that have been shown: viral meningitis, glandular fever, hepatitis. If you follow these patients up 6 months later, up to a quarter of them will have chronic fatigue. Again, the more specific you get with the definition, the less the proportion gets, the more, depending on how strictly you define it as chronic fatigue syndrome. I think the important thing is that common viruses are not associated with triggering this illness. It's really these severe viruses that do it. And this is just to emphasise again that there are risk factors for who are these people. The past history of psychiatric illness is there, if you've got a history of prior similar symptoms, and also what you do when you get ill. And this comes on to perhaps more of the sort of psychological aspect of developing CFS. Moving on to the perpetuating factors, I'm just quickly going to review the psychological ones because I think they're going to be talked about later before I go on to talk in more detail about the biological factors. So the sorts of things that people look at are cognitive factors that may be important. As I said, what you do when you get ill, how you deal with your symptoms, behavioural factors, whether you develop a comorbid psychiatric illness as well, and a number of social factors. Peter's already talked about what happens, what doctors do makes a difference. What about biological factors? There's been a number of different candidates that have been looked at. As I said, it's almost always been looked at the perpetuating level because we just don't see people early enough in the condition to do much else. The sorts of things that are in the literature are the neuroendocrine axis, so looking at cortisol levels, and I'm going to talk a bit about that. People have looked at circadian rhythm changes, disrupted sleep, whether those two are linked, and also general hypothalamic disturbance. There's been work on neurochemical factors. Are there changes in the brain itself that you can identify as important? Been quite a lot of work on the autonomic nervous system, looking at various aspects of that again that may be important perpetuating factors. And there's literature on what happens when you're intermittently or prolonged, for prolonged periods, inactive. What does that do to your body? And one of the things I'm going to come to is that when you're looking at these aspects, it's very difficult to single out what may have been present early in the illness at the beginning and what may have become present late on in the illness when you've been ill for several years. To some extent, it doesn't matter if they are causing problems. I'm going to talk about cortisol. If low cortisol is present, which we think it is, does it matter if it came on first or does it matter if it came on later in terms of having an effect on you? Probably not. But it does matter in trying to understand what are the actual underlying causes of the illness. And just to dispel a couple of myths about the biology of CFS, which are sometimes put about. The first one is that psychiatrists are not interested in finding biological causes of CFS, that all we're interested in is the psychological or psychosocial aspect. Problem there is that if you look at most of the work that's been published about trying to unravel the biology of CFS, it's actually come from psychiatrists, either on their own or in collaborations, most of the work in leading journals. So we are interested in it. We're not interested in looking at it in isolation because that would not be a full understanding of the illness. Some people would say if there are biological factors found, then that's all that matters. The psychological factors are no longer important. It's trumped. Once you find the cause, you don't need to worry about the psychological side. And I think that most people would understand that to have an optimal understanding and effective treatment of most biological illnesses, you need a psychological approach too, and there are numerous examples of that. And then finally, that if we also try and understand psychological factors, this somehow means that we're ignoring biological factors and somehow minimises the illness. As I said, if that were the case, we wouldn't be spending a lot of time investigating the biological factors and trying really to understand what they mean and how they occur. But there is still a stigma about psychological factors, and we're often fighting against the stigma that if once there is a psychological element, then that stigma can come into play. So moving on, I'm going to talk about how this multifactorial approach to addressing understanding biology, it can be exemplified by the Hpa axis, which is a factor which has been widely looked at and something that I've been involved in extensively over the last 10 or 15 years. It is out there, this idea that there's some sort of adrenal fatigue syndrome. There are adrenal formulas you can buy, adrenal forces. I think generally they they sort of get adrenal glands from unfortunate animals, mash them up and put them in tablets. But there is this idea that there's some sort of adrenal fatigue. Is that true? What's the evidence? Well, just to remind you about what you probably already know, we're talking about the Hpa axis. The hypothalamus, stress acts on the brain, affects the hypothalamus, which releases CRH. CRH goes down the portal circulation to the pituitary gland. In the pituitary gland, it stimulates the release of ACTH, which acts on the adrenal gland to cause the release of cortisol and other corticosteroids, which have their metabolic effects. And there's a nice feedback pathway that keeps this system in order. So the first question is, well, is there actually low cortisol output in CFS? We published a study a few years back which looked at patients attending the clinic and measured the total output of cortisol over 24 hours in the urine. We had a group of healthy controls, a group of patients with CFS without any other things going on, so they didn't have fibromyalgia, they didn't have depression. This was how we were trying to exclude those other influences. And we did find there was about a 25-30% reduction in the amount of cortisol put out by these patients over the course of a day. We also moved on then to look at the circadian rhythm by using salivary cortisol. They can spit into pots across the day from 6 in the morning to 9 at night. This is a group of controls throughout the day, the usual morning peak when you wake up, declining throughout the day. And this was a group of patients. So again, you can see if you, on a different measure throughout the day, a reduced output of cortisol. We also looked at ACTH. We got patients into a research unit. We admitted them overnight. We cannulated them, and we took blood samples every 15 minutes. And this is the period from 10 p.m. to 10 in the morning. As you see with ACTH, this purple line is the controls. There's a gradual rise throughout the morning and a particular peak first thing in the morning, which is stimulating cortisol release. But in our patients, there was a lack of this morning peak. So they had a lower morning surge in ACTH. So there's something going on. And summarising the literature in the systematic review a couple of years ago, overall, about half of the studies have found patients have low cortisol. Not all of them. If you look, a lot of studies don't find this, but about half of the studies do. And this needs some explanation. My favourite explanation relates to, I guess, the heterogeneity, the fact that there are different samples being studied here. And we're probably not looking at some simple explanation that all patients with chronic fatigue syndrome have low cortisol. But it seems to be that certain samples, certain patients do have low cortisol. So why do they have low cortisol? Is there something wrong with the Hpa axis itself? What happens if you try and challenge that axis, try and stress the axis? Is there something about the response to stress broadly defined? Well, we undertook a series of studies looking at the CRH test. I showed you the diagram earlier. CRH acts on the pituitary gland to cause the release of ACTH and then cortisol. So we gave a group of patients and a group of controls a standardized challenge in the morning. This is the healthy control response. And this is the chronic fatigue syndrome patient response. So there's a blunted response to challenge. The adrenal gland doesn't respond normally to a standardized challenge. We also did a more naturalistic study. That's a pharmacological challenge with a very large stimulus. This is a more normal stress. This is waking up in the morning. What you find when you wake up, well, if you measured it, you'd find it, is that you do get a rise in cortisol over the course of the first hour. This is the normal response. When we did this with our patients, we found that they had, again, a reduced response to this more physiological stressor. And that was, if you measure the overall output, it's down about half in the study. So, in summary, again, this was studying the literature, all the studies done a few years ago. There's lots of different challenges that have done, lots of different ways that you can activate the Hpa axis. when I looked at these, overall, 11 of the 16 had showed a blunted response. None had showed an enhanced response. So again, it suggests that it's not by any means conclusive, but it does suggest that the overall trend is suggesting a blunted response of the Hpa axis to a variety of challenges. Now, I talked about confounders. It's important that we try and, as best we can, understand what else may be causing these results. Depression is an important one because depression itself is associated with changes to the Hpa axis. This was just one study suggesting that about half of patients with CFS have depression. It varies depending on the samples and the definitions of depression. But we clearly have to control for depression. So we did that. We looked at people. This is the same urinary cortisol output over 24 hours. This is the same slide earlier. But this time we also looked at patients who had comorbid depression. And actually, that wasn't a factor that seemed to explain things. Even if you had comorbid depression, you still had a reduced cortisol output. We looked at people who were inactive. We thought inactivity might be something that's important. We wanted people who, by reasons other than CFS, were inactive. We chose a group of patients who had fractures or sprains or something that meant they're off their feet for at least at least 4 weeks. We didn't see any difference between the sort of normal controls and these inactive controls in their sort of medium-term inactivity. Certainly, these controls were not inactive for anywhere near as long as these patients were. But it did suggest that 4 weeks, 6 weeks of inactivity isn't enough to change your Hpa axis. We also did a stimulation test in these inactive control patients, and they had exactly the same response as the healthy controls. Sleep disturbance is something that others have looked at, whether this is a confounding factor. And it does seem that sleep is something to be very careful of when doing these studies. One study looked at simply changing your sleep pattern for 5 days, looking after you've been on night shifts when your sleep is more disturbed. And what they found was that in these people with disturbed sleep patterns, there were low cortisol levels. There was this same blunted response to challenge. So similar pattern to that seen in CFS. So sleep, I think, is something that needs more study because it's a likely confounder, and as we've heard, sleep is frequently disrupted in CFS. So does low cortisol matter? A proportion of patients probably have it. What's the clinical significance? Well, we undertook a study to see if a small replacement dose of cortisol, hydrocortisone is the pharmacological name for cortisol, a small replacement dose of cortisol would alleviate some of the symptoms. And this was a crossover study, a randomized controlled trial, in which patients received a month of placebo followed by a month of cortisol, or a month of cortisol followed by a month of placebo. And it was a low dose, a dose, and the normal output in the day is about 30 milligrams, so we're giving about a 25% supplement, which was the level we found urinary free cortisol was reduced. And this is the outcome in looking at fatigue. These are patients who had, this is a change in fatigue from baseline, patients who had placebo first, followed by cortisol, and you can see a small placebo effect followed by a treatment effect of about a 25% reduction in fatigue, and then you see the active treatment first, a 25% reduction in fatigue, that wore off when patients went on to placebo. So it does suggest, at least in the medium term, short to medium term, that if you raise patients' cortisol levels, they experience a bit less fatigue, although we're talking a 25% reduction. It's not a massive effect. They were also a bit less disabled. Disability scores were 10 to 20% less if you're on active treatment compared to placebo. And interestingly, when we looked at the endocrine response, this again is the CRH test. We have patients in yellow on baseline, that's what I've already showed you, their blunted response. On placebo, they still had a blunted response. In green, we have what they were like on an active response when they responded to treatment, and this dotted line is controls. So those who had active treatment, who responded with a reduction in fatigue, their endocrine response also normalized back to control level. Now, I mentioned this difficulty that we're studying patients at the end of illness. we've tried to take that forward a bit and say when during the course of development of this illness do changes in cortisol occur. And we've done a couple of prospective cohort studies trying to measure this. Just remind you, we're looking at this multifactorial model again. We're trying to say, can we get a better handle on what's happening here rather than just looking here? Well, the first thing we did was we took a cohort of patients who had glandular fever, Epstein-Barr virus, and we studied them from the day they were diagnosed. And we followed them up for 6 months. We found quite a high rate of fatigue. I've already shown you that that's not unexpected. If you look at those who had fatigue at 6 months, it was 40%. And over the course of the 6 months, 11% had been continuously fatigued for the whole of the 6 months. Well, we looked at cortisol profiles when they were diagnosed and at 3 months and 6 months. And this is the total cortisol output in those who were cases of fatigue and those who didn't develop fatigue at baseline, 3 months and 6 months. Essentially, there's no difference between fatigue cases and non-cases. So we couldn't identify a risk factor when you got the illness or a risk factor in the early stage of fatigue related to low cortisol in that cohort. The second cohort we looked at was post-operative fatigue. I mentioned that there is a literature suggesting rates of fatigue after operations. The advantage of this cohort was that we could study them before they had their insult. So we could get them before their operation as well as follow them up afterwards. We had 4 groups of surgery, and again we took similar salivary cortisol profiles across the day to measure the cortisol output. This is what happens with fatigue with the different surgical groups beforehand, immediately after the surgery, 3 months, 6 months. So we're looking at this fatigue syndrome and these patients here who still have fatigue. Is there any change in their cortisol? But this is a slightly complicated slide. The important thing to note is that those who were fatigued at 6 months didn't show low cortisol at baseline through to 6 month follow-up. If anything, they had a slightly higher cortisol. They had a slightly higher stress response to the surgery. This effect was really wearing off by 6 months. So we certainly couldn't find the same pattern that we see in the long-standing CFS patients of low cortisol in this group. So in conclusion, we couldn't find in acute or subacute fatigue any link to low cortisol. We couldn't find a link in the early stage of chronic fatigue, this 6 months cut-off point. But we still have this finding that in late chronic fatigue there is low cortisol. I mentioned the possibility of high cortisol as a risk factor that may relate to some of these other factors that are important, but I don't think there's enough evidence to say much more than that at this point. So I think what we've built up is a multidimensional model of the Hpa axis in CFS. A number of things affect whether you have an Hpa axis disturbance. The phase of illness, whether you have sleep disturbance, whether there's a comorbid psychiatric illness, a history of abuse in the past, what medication you're taking, whether you're under stress, how active you are, whether there's any weight changes, dietary problems, and genetics. There's emerging evidence of genetic polymorphisms that may affect the Hpa axis that may differ, but it's too early to make many conclusions about that. What I think is that these things affect patients variably to differing extents, and that there's an Hpa axis change that's heterogeneous. You cannot say it is a certain type of change. There is a hypothalamic disturbance or an adrenal disturbance, because it depends which of these factors are active. There does seem to be a final pathway in some patients of low cortisol, and I think it's likely that that low cortisol in the late stages of chronic fatigue is a maintaining factor. What can you do about it? Well, I showed one randomized controlled study, but I think that's not enough to suggest that this should respond to pharmacological management, particularly when we know all about the difficulties of giving people steroids in the long term. I'm not going to say much about cognitive behavioural therapy because I'm sure it's going to be discussed later, but essentially we moved on to test the theory that if Hpa axis disturbance is related to some of those factors, like inactivity, sleep disturbance, then therapy such as CFS that targets those factors should reverse the Hpa axis changes. There's good evidence that it works. But what does it do to the Hpa Axis? Well, we studied 100 patients before and after they had 6 months of CBT, taking the same measures that we've taken in our earlier studies. This is salivary cortisol profile across the day. In red we have before treatment, and in yellow we have after treatment. It's a subtle effect, but if you add up throughout the day the output of cortisol, there's a significant increase in the amount of cortisol patients output after treatment with CBT. If you look at the output of cortisol with challenge from the CRH test, again, after CBT, there's a significant increase. So this blunting that's present beforehand is reversed back towards normal. We also looked at who responded to treatment. In this study, 43% at the end of therapy had responded. That's a real-world figure, and actually that 43% goes up higher towards a sort of 50-60% after a further period of months. But at the time we retested them, 43% were responders. And what we actually found was that those who had the lowest cortisol outputs before treatment had the worst response to therapy. So those who responded had higher baseline cortisols. So again, it suggests that low cortisol may be some sort of maintaining factor that makes response to CBT alone more difficult. So in conclusion, CBT does have biological effects, even in the presence of modest clinical effects, normalization of the Hpa axis, and it was probably working via a normalization of factors that mediate the Hpa axis disturbance, such as sleep and physical deconditioning. So, conclusions about the Hpa axis. It is changed in the direction of low cortisol output and a blunted response to challenge in a proportion of patients. It's not a uniform change, doesn't affect everyone, probably related to several factors and occurs later in the honours course, but it's probably got symptomatic significance as a maintaining factor. Now, and it's reversible by CBT, which I think is important. Now, if I've got 2 minutes left, just to one other set of studies looking at serotonergic function. I mentioned that there was interest in the brain chemistry, and a couple of slides just on some work looking at brain changes. We first started looking some time back at the response to a serotonergic drug. If you give someone a serotonergic challenge, just like if you give them a challenge to the Hpa axis, you can stimulate the neuroendocrine axis. This works on 5-HT, serotonin, and you can measure the prolactin response. And we gave this to a group of control subjects, a group of depressed patients and a group of chronic fatigue patients. As you know, probably in depression, the theory is of low serotonin, blunted serotonin, and we found that. But we did find a heightened serotonin response in our patients with chronic fatigue that was quite distinct from that seen in depression. So we went on to look at the brain and to see whether we could actually see anything in the brain with 5-HT receptors based on this. And we used a radioligand called WEI-100-635 that binds to 5-HT1A receptors. We looked at a number of patients with chronic fatigue syndrome, and we did find some specific areas of deficit of 5-HT1A receptors in the brain, which appeared to be, this is hippocampus. There was a widespread general reduction in 1A receptors, but most notable in the hippocampus. And this is the patients compared to controls. You can see on the left and the right, the binding in the hippocampus is reduced compared to controls. So, again, the same caveats apply. This is work that needs to be looked at in terms of the overall multifactorial model, in terms of the other factors that may be present, and in fact, you see a similar pattern to this in depression. So, just to say in summary, I think there are several emerging areas of interest that may be relevant in understanding the pathophysiology of CFS. I've just reviewed a couple, haven't got time to go into all of them. But I think the understanding has to be part of a multifactorial model that includes predisposing, precipitating and perpetuating factors, because biological factors can operate at each of these levels. The biological models are complementary to psychosocial models, as should be the case in all biopsychosocial medicine that we practice. I think it's unlikely that there's one biological process. This fits in with the notion that it's unlikely there is one chronic fatigue syndrome. And it remains unclear where the boundary will lie between chronic fatigue syndrome and other fatigue states as I've shown in the earlier slides. Thank you very much.